I've known Dr. Spiegel for a long time, so I'm going to be introducing him. And it's been probably about 10 years, and this man is just a powerhouse and an amazing force, both here locally in Vancouver and in Canada, traveling across Canada and doing a lot of great work academically, but also in the community. And I think he speaks highly to sort of the values that we have in Canada in terms of marrying your work and also your community work. So I've known him from his work in Bhopal, and he did a lot of organizing to help the people of Bhopal after their spill. And it's quite timely, especially what we're seeing nowadays in Japan with the potential there. So I think people who do both academics and also stuff in the community are definitely true heroes in the country. So in terms of his academic stature, he's an associate professor at the Liu Center of Global Issues and also at the School of Population and Public Health at the University of British Columbia. His research focus predominantly focuses on strengthening the capacities to address determinants of health. And he currently leads active collaborative projects in Ecuador, Cuba, South Africa, which focus on environmental and occupational health risks. He was also and is the founding president of the Canadian Coalition for Global Health Research. So please give it up for Dr. Spiegel.
Just switching over. Oh, great. Well, thanks very much for those overly kind words, AJ. But it's a great delight for me to be here tonight to address an issue that is generally not given the attention it deserves. Deserves if we're really serious about what the title says, improving global health. The story I've been asked to tell, to relate, to start the evening, really relates to what it is we mean by global health. And when I address the issue, I like to use what's called an illusion, or something where you look at an image and you see many different things, and it really challenges you to see what it is that you mean. And that's really the topic of global health to a T. Now, if we think we're actually seeing an explosion of the use of this term, well, you're right. We are seeing a far greater use of the term global health. And if you could see on the graph that I have that sees the mentions in the 1950s were very marginal, particularly for global health. And then we see an increase in those mentions from one decade to the next. So from under 1,000 in the 50s, we have 11,000 mentions of international health. Still global health paling behind. But yet when we get to the year 2000, we see really that explosion taking off, and we see global health displacing international health in what's commonly used. And remember, for looking at this graph, those are just 5-year intervals on the right, so it's even more than it appears. When we look at this concept, well, why do we have this attention and what's at stake? A map that I use with my students is what the world would have looked like if the slogan Health for All by the year 2000, which was bandied about at a time when I was a student, if this dream had been realized. Well, if you have a color code for positive outcomes, the globe would look green if green was a good outcome. In this case, the image that I'm projecting is one of maternal mortality. One could look at a world like this, but unfortunately, the world of health for all has been a health for some by the year 2000. So we see right off the bat great disparity, and we could look at a number of indicators: under 5 mortality, infant mortality, life expectancy, and we see an unfortunate diversity, and we see some parts of the world, notably in sub-Saharan Africa, but other parts that are plagued by this challenge. When we look at what global health then means in the current day and age, we see it being evoked from things like the Bill and Melinda Gates Foundation that have energized a lot of activity to address some of these challenges. And Grand Challenges Canada is a new initiative that tend to focus on concentrated efforts, often with a particular focus on technological innovations. But there's a bigger story when we look at global health. That's really a tip of an iceberg. When we look at why international health may not capture what global health does. The best quote that I like is one that said, international health became global health when the causes or consequences of a health issue circumvent, undermine, or are oblivious to the territorial boundaries of states, and thus beyond the capacity of states to address effectively through state institutions alone. So we're really saying we're talking about something that you can't just address effectively in your own backyard because you may not have the resources, because the forces that are reproducing this problem may be greater. And typically when we're talking about global health, we're looking at three basic concepts. We're looking at systemic relations that have a local presence, but also a global set of pressures. We're looking at equity and disparity in the world that we know. And we're looking, above all, at the question of what is our capacity, what are our capabilities to improve this. So when we think of diseases, and health, after all, is really more than diseases, but if we look at diseases as an attention, we could look at a whole host. We could look at HIV/AIDS, which we see has been very prominent with the pandemic, but we could look at a host of other illnesses, and we could be drawn right away to kinds of medical interventions. But it's more than a technical fix, because we have to say, if we even have a solution, can we get it to people? Is it accessible? Will it in fact work in practice? So it's more than that. And we have to remember that health itself is one part of well-being. And we have to look at very creatively at different approaches to health and not prejudice one against another and have too narrow a definition. An area that I particularly am focused on, as was mentioned by AJ, is looking at the determinants of health and the conditions. So we really have to look not just at treating a case, but looking at the circumstances that allow that case to emerge and maybe reproduce in that person again, or many others, or broader populations. So we have to look at things like water, sanitation, etc. But even that takes place in a context that may be more difficult to address, but may have great power if we look at questions of literacy, poverty, conflict, and that in turn relates to broader socio-political, economic conditions that, again, can be the subject of things that people do. So in addition to treatment, we have to think about what we can do to prevent. We go back to looking at that world of disparity, and World Mapper is a great device that tells a great story in an image. If we saw the world the way a particular parameter or area of concern inflated or deflated a part of the world that we know, when it comes to TB cases, we just had a Stop TB meeting in Vancouver a few weeks ago, and we used these slides. We see Africa and sub-Saharan Africa very prominent. We see India very prominent in this map, far beyond their populations and their geography. If we go and we look at the image of nurses working, all of a sudden Africa starts to disappear. So we see that there's tremendous disparity. When we look at that notion of nurses and we think about the capacities needed to address this, we see that we have a version of a 1090 gap that we use in terms of global health, where we have an imbalance of where attention is paid to where need or a burden of disease is felt. In this case, you see that the majority of health providers are located in the Americas and Europe, while the burden of disease is felt disproportionately in Africa and Southeast Asia. So we have a challenge there, and the observation that there are more nurses from Malawi and Manchester than in Malawi is a sobering thought. In fact, when we look at the question of migration of health workers, which is receiving a particular amount of attention as a particular diaspora that we're seeing, we see that in addition to the flow from docs from Canada to the States or England to Canada, we see that it has a particular inference for low and middle income countries. When we think of northern British Columbia, northern Manitoba, where I lived for many years, the physicians there are from South Africa. We see in turn that there's a migration from countries like Malawi and Nigeria of physicians to South Africa. There are many factors that influence this, including the dysfunction of the health systems in people's own countries. So we look at that, and we say, wow, the flow is actually aggravating the problem, not being used to channel it. One country that I do work in, Cuba, for 15 years, is really the only country that I think has been a shining example of dispatching resources and capacities and training people. But we developed with colleagues who we had met in South Africa an initiative to try and make the health sector a healthier place to work by improving the work environment. And as we started to do that, we realized there were many problems in common, but many things that were different. And we could be far stronger if we linked up with people who knew this. So in our team, we have a member of the South African medical diaspora who actually had very close working relationships with the people we're working with today. A great relationship. For different reasons, he ended up in British Columbia, but is really strengthening our capacity to work together. So when we go back to like an accepted division, a definition rather, of global health that appeared in the Lancet a couple of years ago, it says global health is an area for study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. Global health emphasizes transnational health issues, determinants, and solutions, involves many disciplines within and beyond the health sciences, and promotes interdisciplinary collaboration, and is a synthesis of population-based prevention with individual clinical care. A shorter version of this that's punchy that I quite like just says collaborative transnational research and action for promoting health for all. Inspired by these words and these experiences, we'd undertaken a 6-year collaborative project that's been very rewarding in Ecuador to be looking at environmental health. As we took this on with the funds from the Canadian International Development Agency, we realized our team was facing challenges in terms of knowing how to work. And we were fortunate that in the Vancouver community, at a meeting that we held on this topic, 2 members of that community came, expressed interest, became volunteers with the project, and Veronica Moreno and Rosamilia Andrade became central people as coordinators of the project. We were able to hire them on. And it gave us a capacity to really understand, and it gave them a capacity to link back to their communities. When we did this, I also was inspired by meeting Dr. Shafiq Pirani, whose story you're going to hear today in terms of how diasporas can really make a difference in terms of improving global health. So to summarize then, the messages that I like to look at in terms of global health collaboration are emphasizing with more than for, because it's really how we can work together to address a challenge that may be burdening a certain part of the world in this global community that we're in, but we have an opportunity to learn and assist in that regardless of where we are. There's a particular challenge for people who are on site, but it's part of our world, and frankly, we could learn a lot from that, and we've actually can share many examples and stories of how that learning is being applied here in Canada. Local knowledge and mutual learning are essential elements. How do you achieve that? You don't tell someone, you have to learn together. There has to be an intercultural understanding, and that's a capital C for cultural, but just from different experiences, but very much when we're looking at different parts of the world. And finally, that brings us to what's Canada's multicultural niche. Looking at the map with all the flags on the way in to the room here, we see what a diversity of experience. If we're really serious about having an impact, having a positive contribution, that is a tremendous strength. And when I was president of the Canadian Coalition for Global Health Research, we've always talked about how the diaspora should be addressed, but it's really an event like this that's the first one that I'm aware of that puts it center stage. So I'm very much looking forward to the stories, because that's where the richness is. Thanks very much.
We can probably entertain 2 comments, and just to lead it off, I mean, the concept of health for all, I think, resonates with many people in the room, as well as the idea of going from international and systemic boundaries to going more of that global terminology. Why don't we take the first one? Yes. And when you do speak in the mic, just mention your name, and if you're with an organization or a group, just mention that as well.
My name is Samson Nabimba. I'm the director for Youth as Volunteers Integrated Network Society, which works in East Africa and Canada, but mostly in Uganda. My question and comment is directed to the previous speaker. It seems that we have a lot of data that we have collected, but one of the problems I find that maybe the question I have for him is that how can we ensure that we walk the talk? Because you realize that the Canadian government, for example, is pulling out of its resources from Africa when the problem was not being solved. You realize, from my experience as a social worker in East Africa, in Kenya, Uganda, Rwanda, and Tanzania, the biggest killer of the children, for example, now is AIDS. Malaria, which is preventable. It's most likely it's going to surpass HIV. And another problem that is common right now, the high levels, high rates of women, mortality rates for women while giving birth, it's like getting it soaring high. So based on the fact that the government of Canada is pulling out, you as medical professionals and bureaucrats, how can we ensure this does not happen, or how can we be ensured that the work that they have set on the ground doesn't end? One solution I have for bureaucrats is this. Can we work with the private enterprises, for example, in Africa? In West Africa, it may not work, but in East Africa, it may work because of corruption, because of so many issues. We find that the private NGOs can work better than the government, because you remember, one of the points is that for example, in Uganda, where I come from, the Global Fund for HIV were all swindled. So why can't we focus on the private enterprise? Thank you very much.
Yeah, no, I think, there's two excellent points there. One is walk the talk in terms of focusing on areas of priority, and the second is looking at the diversity of capacities that could be drawn upon to address it, especially looking at the challenges. One thing that I think we should really focus on, there was just a poll that was published, and I see it periodically last week, the people's perception of what international assistance is from budgets. This was U.S. data, but I don't think it would be terribly different in Canada. People have a very inflated idea of what the amount of money that goes into development assistance is, and have a certain disdain for things that they see that are waste, but on the other hand, have a tremendously high opinion of the need for addressing the kinds of issues that you were talking about. So I think there has to be a better job of understanding what, in fact, how we're walking the talk, if you will, where the funds really are, that it isn't that there's excessive funding that's been going into these areas. And those have really, when we had a consultation on foreign policy, the expressions that I saw from Canadians were seeing a lot of respect for addressing the kinds of issues that you were saying. So we really have to make that known in our discussions with our political leaders, in the media, etc. So we have a reality. Then when we look at what can work, we have to address what can make a difference as a catalyst, but then I think we still have a challenge to look at how we can make those systems, even the systems that are plagued by corruption, how we could reinforce forces that can drive out that corruption in that country. And that's why I emphasized with rather than for. But I think a key question is catalysts, and I think you put your finger on it to say what can actually work in a setting, and let's try and make that happen.
Good. We'll take one more question. Jerry, maybe I have one for you then. Talking on walking the talk, do you want to just share quickly a little bit of your collaborative model and how it's been working, and how researchers and people in the communities actually get the real work. So it's not like you're just going in, doing the work, and leaving.
Perhaps an interesting kind of story in this case was how we ended up doing the work that we're doing in South Africa. Just as a story, because what happened was my wife, Dr. Annalie Assey, had headed an initiative that was looking at the health of health workers in British Columbia, and through use of information to be training to identify areas for greater prevention of problems in British Columbia. There's problems of musculoskeletal problems for nurses and other health workers, violence, things like that. So by better training, better organizing, better use of information, there were significant improvements made. We shared that at a meeting of centers of excellence for occupational health in Europe, and there was the head of occupational medicine for South Africa and the head of their National Institute for Occupational Health. They were very interested because they have far more severe problems, the problems of extreme drug-resistant TB, problems of HIV/AIDS, where there's a 40% prevalence rate. In addition to being a huge challenge, it's a huge challenge for health workers. So they were very intrigued by having this intervention because it was a priority. They weren't sure what to do. We went to Johannesburg, had a series of workshops, and at that meeting, it was decided we should have an initiative. There were people from different hospitals, and one person who was very enthusiastic from a regional hospital in Free State was saying this could fit. We went, we visited 5 sites, we had criteria, and the site that Lucky Noftali was talking about was proven. So through that led to other meetings and more stories. So it was very much a grounded experience. Things start in different ways, but I think the key thing is we've really developed a collaboration and a team, and that's why I really emphasize with rather than for.